Good morning, everyone. I am Dr. Manoj Kapoor, working as an assistant professor in cardiac anesthesiology department at UN Mehta Institute of Cardiology and Research Center. Today, we all will be discussing the topic for transesophageal echocardiography for congenital heart disease, for atrial septal defects and atrial anomalies, part 1. A brief summary of what we will be discussing today would be, first of all, a short review of the embryology for understanding the basic development of the atrial septum. Then we will look forward to the rims of the ASD that we will have to evaluate, especially in a case of device closure. Then the goals of examination for TE and the complete evaluation of the interatrial septal defect, what we will have to do. So proceeding with a brief summary of the embryology. First of all, we all know that there is a common atrial chamber in which during the development septum primum it grows from the above end and grows towards the endocardial cushion that we can see here. This is the septum primum and this is growing towards the endocardial cushions. Now the septum primum it doesn't reach fully the endocardial cushions, and there is a gap in between which is called the foramen primum. Now in the further course of development, the septum primum completely fuses with the endocardial cushions, but there is a second gap that develops in the septum primum, and that is termed as foramen secundum. Now this foramen secundum helps during the intrauterine life and it helps in the fetal circulation. During development, another septum grows from above downwards, and this is called septum secundum. With due course, this two septum fuses and it causes a flap-like mechanism. During the intrauterine life, there is still flow from right to left, but when a baby is born, within few hours, this flap closes physiologically and afterwards anatomically, and the foramen secundum closes. Now proceeding forwards, we will look towards what are the rims for an ASD. These rims are important for evaluation while doing a device closure for the ASD. Now we name them anatomically, and as we can see, there is an aortic rim, there is a mitral or AV rim, then there is a coronary sinus rim, there is an IVC rim, there is a posterior rim, there is an RUPV rim, and then there is a SVC rim. These rims are they are named according to the anatomy and according to the spatial context of where they are present. On the anatomical nomenclature, we have the RUPV, the mitral rim, the coronary sinus, aortic, SVC and IVC rim. And according to the spatial configuration, we have the posterior, anterior inferior, inferior, anterior superior, posterior superior and posterior inferior rims. In the further discussion, we will mainly focus upon the anatomical rims. So beginning forward with the rims that we will have to evaluate. The first is the posterior rim. This can be seen in a mid-esophageal 4-chamber view. On the upper side, we don't have to angle it much. We can see it in a 4-chamber view, and we'll have to measure it and to get the size of the rim. Ideally, the rim size of all should be around 5 mm. That will ensure a good attachment of the device that we will deploy. So measuring the posterior rim in a mid-esophageal 4-chamber view. Secondly, in the same view, we will get the AV rims also. The AV rim is also nomenclatured as mitral rim because it is formed from and supported by the AV walls. So this rim can also be seen in a 4-chamber view and can be measured. Going forwards, we will do the RUPV rim. The RUPV rim is typically seen in a mid-esophageal view, but we'll have to slightly pull the probe, the TE probe out, and slightly rightward rotation is required to see the RUPV rim. And we'll have to measure it, the length of the RUPV rim. Fourth, the aortic rim. This is a very important rim for device closure, though it is not mandatory, but we want it at least to be 5 mm or above that, so that we have a good deployment of the device. To achieve this view, we have a mid-esophageal aortic valve short axis view. So we remain in the mid-esophageal position and rotate the angle to 45 degree, where we can see the aortic valve here and an aortic rim that is seen protruding. We have to measure it, and we can also see the remaining ESD in this view. And from the aortic valve to the end of the rim, we will have to take that. If it is small, it makes the procedure challenging, but it does not contradict the procedure. We can still, if we have a rim or at least 3 mm, we can progress or attempt for a device closure. Now going forwards, we will look upon the SVC rim. The SVC rim can be seen in a mid-esophageal bicaval view or modified bicaval view. We will have to, from the mid-esophageal position, we have to rotate the probe to the 90 degree, and here we can see a view in which SVC and IVC both rims are visible, and the SVC rim is to be measured from the superior lip of the ASD and up to the insertion of the rim into the SVC. Here also we can visualize the ASD well, and the float, which we will discuss further. The IVC rim also is visualized in the same view. If it is a fundamental to obtain this rim and get the length of it, because the device closure would be challenging in its absence. It is, however, usually the most difficult to measure, and retroflexion of the probe can help us to get the exact size of the IVC rim. Now the coronary sinus rim. The coronary sinus rim is visualized when we insert the probe slightly deeper from the mid-esophageal four-chamber view. When we visualize the coronary sinus, we will get the rim, and we can get the measurement for that. Here in both these pictures, we can get the measurement for this coronary sinus rim. It is necessary to perform a slight retroflexion of the probe to obtain a view of both the lower end of the ASD and the coronary sinus. Now these are the criteria for the ASD device closure. Usually for device closure, an ostium secundum ASD would be preferable or easier to accomplish. The size of the defect should be less than 4 cm. The rims of all the rims should be of more than 5 mm, and the pulmonary pressures should be less than 2/3 of the systemic pressure, and the pulmonary vascular resistance should be less than 2/3 of the systemic vascular resistance. This is important as in a case of long-standing ASD, we usually see pulmonary artery hypertension, and closing an ASD where there are suprasystemic pulmonary pressures can lead to RV failure or further exacerbation of the pulmonary artery hypertension. Now we will go forwards for the goals of our TE examination. Now first of all, we will have to evaluate the anatomy of the atrial septal defect or patent foramen ovale, and in that the size and the location of the defect. Size is important to assess the amount of shunting that is happening, and the location of the defect. As in the further lectures of the ASD, we will discuss that there are various types of ASDs, ostium secundum, ostium primum, coronary sinus type, and various other types, sinus venosus types of ASD. So we will have to confirm which type of defect is that, and also we have to confirm that any other defect, if it is present or not. Septal rims, as we have discussed, the septal rims and their length, the septal anatomy, and the direction of the atrial level shunt. Secondly, we will have to assess the drainage of the systemic and pulmonary veins, whether in especially in a case of we will now look for the goals of our TE examination whenever we are doing a TE examination. So what would be our goals for that? So first of all, the anatomy of the atrial septal defect or patent foramen ovale. Here we have to assess the size. The size is important as the larger the ASD, there are more chances of development of PH, and the location of the defect. Means that there are various type of ASD as we will discuss in the further lecture: ostium secundum, ostium primum, sinus venosus, and coronary sinus types of defects. So we will have to confirm which type of defect is it, and we will have to see if there is a single defect or there are even multiple defects. We will have to ascertain the septal rims that we have discussed, that what are the sizes of the rims, and especially in a case of device closure, we will assess the septal anatomy, on which direction there is, and also the direction of the flow. We will have to assess. That will guide us on the flow, the right to left flow shunting is there or left to right shunting is there. It will help us to assess the pulmonary flow and the systemic flow and the resistance. Secondly, we will have to assess the drainage of the systemic and the pulmonary veins, especially in a sinus venosus defect. We will have to assess whether the pulmonary veins are draining into the LA, or there can be an anomalous drainage of the right pulmonary vein into the RA, which can lead to deoxygenation or poor oxygenation. So we will have to ascertain that all the pulmonary veins are draining into the LA. We will also have to assess the atrial chamber size. Large RA or large dilated RA-RV indicate that this is a case of where there are chances of development of PH or RV failure. We'll also have to assess the Doppler assessment for the AV valves, the mitral valve anatomy, especially in the cases of AVCD, atrioventricular canal defect. We have seen that there is also a mitral cleft and there is MR. So we'll have to assess the mitral valve for any cleft or any mitral valve regurgitation, that we'll have to assess, and also the tricuspid valve if there is any abnormality or any regurgitation. And assessment for the possible pulmonary hypertension, estimation of the right ventricular and pulmonary artery systolic pressure through the TR-jet, and estimation of the pulmonary artery diastolic pressure by pulmonary regurgitation and diastolic velocity. Through the TR-jet, we can get the systemic pressures of the pulmonary artery and the diastolic pressure by pulmonary regurgitation and diastolic velocity. This will help us to assess the pulmonary artery pressure status and whether we can progress towards the closure of this defects. And we'll also have to assess the configuration of the intraventricular septum. Now, also the identification and evaluation of other associated congenital lesions, because with an ASD there are associated VSD, and also, as we have discussed, AV valve regurgitation and anomalous drainage of the pulmonary veins. So now we will progress towards the TE examination for an interlateral septal defect. So the basic where we will start is measuring the diameters of the defect. So the maximal 2-dimension sizes are taken in 2 orthogonal views. First of all, in a mid-esophageal 4-chamber view, we will get the transverse transverse defect at 0 degree and the maximal longitudinal defect at 70 to 90 degree. So we will take the 0 degree, the mid-esophageal 4-chamber at 0 degree. We will measure the defect size, and that would be the transverse diameter of the defect, and then we will rotate the angle to 90 degree, and here we can get the longitudinal size of the ASD and the defect. And further, the mid-esophageal 4-chamber view represents a starting point in the evaluation for the ASD, as it adequately displays the atria the ventricle, the ASD, and the size of the left atrium and left ventricular also. For the evaluation of the defect, we will first of all see the color Doppler. We will put a color Doppler there, and we would see the direction of the flow. What we already know is the true flow is blue away and red towards. So we'll have to assess the flow, the direction of the flow. It will help us to know what are the pulmonary and systemic pressures, and we can also do a spectral Doppler for that, and we can assess the direction of the flow, the quantity of the flow that is occurring. Then after doing the spectral Doppler, we will now proceed to evaluate for the superior aspect of the ASD. So progressive withdrawal of the probe in the mid-esophageal four-chamber view to above the level of the fossa ovalis demonstrates the superior aspect of the interlateral septum. The location of the superior sinus venosus defects as well as the SVC is visible in the cross section, and anomalous drainage of the pulmonary veins as they enter the SVC can be seen in this views. This view is typically important for a sinus venosus defect. Now we will assess the drainage of the right pulmonary vein. So getting a mid-esophageal right pulmonary vein view, we will assess whether the right upper pulmonary vein and lower pulmonary vein are draining into the LA or not. Similarly, we will assess the drainage of the left pulmonary vein. The left pulmonary vein can be visualized in a mid-esophageal LA appendage. We will have to first view the LA appendage at a 70-degree angulation, and then a slight manipulation or rotation towards the left can give us the view of left upper pulmonary vein, and slightly more pulling of the probe can give us a view of the left lower pulmonary vein also, and we can visualize the flow of the veins, and we can ascertain that the left pulmonary veins are draining into the LA. Now we will assess the right atrium, the right ventricle, and the tricuspid valve. So on the four-chamber view, we will get the size of the RA, and if it is very dilated, or it indicates that it is a long-standing ASD and it has caused changes and chamber dilatation, which in the post-operative period will be important, because after closing the ASD, the right ventricular can trouble us, and it may require support. Similarly, the RV dilatation and the tricuspid valve. Through the tricuspid valve, if TRZ is there, we can get the pulmonary artery systolic pressures, and thus we can assess the pulmonary pressures through this. Lastly, the coronary sinus. When we are in a mid-esophageal four-chamber view, we slightly insert the probe and we go deeper, when we can see the coronary sinus, and we can see if the coronary sinus is draining into the RA. If it is an unroofed coronary sinus, if it is draining into the LA, then we will have to ascertain it and inform to the surgeon, and thus the defect can be closed. Now moving forward, we will also get a good view of the ASD in the bicaval view, as we have earlier discussed, and we will get to see the SVC and the IVC and the RA. Here we can, this is a good view to put the color Doppler or spectral Doppler to assess the flow, and also to assess the anatomy of the interlateral septum. In this image, we can see a flap-like valve in the interlateral septum. So this completes our examination of the interatrial septum, and how to evaluate the valve, the interatrial septum completely in the OT or in the cath lab while doing a device closure. The further lectures would be on the types of defect and how to assess them. And thank you very much.